Good morning. My name is Yulia Panayotova, and I work for the Psychology and Health Research Center. I thought of speaking in English, but I see the audience, the majority of audience are Bulgarian speakers, so the presentation will be in English, the slides in English, but I will be speaking in Bulgarian. So I will talk about our efforts to involve women from various social groups in the research that we conduct. Our scientific center is an NGO set up in year 2000, and the purpose is to conduct scientific studies regarding the links, the social, cultural, and health factors in society. The studies that we worked on in the course of years involve young people and women, reproductive health, and screening. One of the main topics we work on is cervical cancer. I will tell you more about that. We studied it extensively. We studied the psychological aspects of patients, the physician's attitude, the pathologies, involvement, and numerous medical staff were involved in the studies. So I believe it's no surprise to anyone that Bulgaria is among the leading top countries with the largest number of morbidity and mortality as regards cervical cancer. Every day a woman dies because of cervical cancer, and this is a preventable disease. We don't have a program to tackle cervical cancer, and that's why we are among the top morbidity and mortality rate countries. That's the role of our NGO. We want to make a difference. The project that we work on is called CBIG Screen. It covers a 5-year period. 14 partners from 10 countries. Among them are Romania, Estonia, Portugal, France, and others. The main objective of the project is to support via research to reduce health inequalities existing in society and among countries. I'm sure that you were aware that there are countries with very good vaccination programs where mortality and morbidity rates are not that high. So there are some vulnerable groups, even though we don't like the word vulnerable groups. All women in Bulgaria are vulnerable simply because there is no screening program, there is no follow-up program. So in that sense, we are all vulnerable. But under the project, we targeted, let's say, the group that is less taken care of, where problems are much larger. This is the model of our project. It includes monitoring, co-creation, together with the women models programs who are developed to convey the proper messages to the target groups. In some of the countries, there will be some interventions in order to test the project deliverables and to reiterate the models in order to improve their efficiency. There are 7 work packages for Bulgaria. Bulgaria is involved in 4 of them. Sorry, 7 are for the entire project. Bulgaria is involved in 4 of them. How far have we implemented the project? These work packages involve various models. The main aspects that we work on involve identifying the vulnerable groups, then identify the proper physicians in order to decide where to look for partners, women partners. We work with our target group very actively, and this is in contrast to some other projects where the targeted group, in fact, represents respondents. And here in this project, we perceive them as partners. In 5 of the countries, collaborative use board meetings were conducted. What does this mean? NGOs, health mediators, project representatives were involved. You are aware that health mediators are crucial when we talk about such vulnerable groups. At the moment, we are at the stage of developing the so-called digital stairs, where they need to develop a message that will be understandable to the target groups, will be appreciated. The most vulnerable group of people, women, in fact, women living in remote settlements. They don't have access to healthcare, to preventive care, and women with lower social and economic status. One of the first steps after identifying the women, we conducted 4 meetings in Sofia and Sliven with representatives of such groups. We spoke a lot about the barriers they are faced with and the possible solutions. These meetings were very interesting because they were attended by diverse representatives. Different barriers were identified. These are the topics we discussed. The barriers for gynecological examination, cervical cancer. Do they know something about it? Do they know about pap smear? What is necessary? Why is it done? And so on. The meetings were very informal and very um, very efficient, I would say. And all attendees actually confirmed that they learned a lot. Um, And now, knowing more, they were more open to visiting the physician. As an outcome of these meetings, we we actually designed our tree of barriers. They had to stick the barriers they're faced with on that tree. We use the colors of a traffic light. So these are the barriers reported by them. Lack of knowledge in their community is a very serious issue. Fear from gynecological examination, some poor experience from previous examination, lack of trust in the health system to the physicians they have addressed previously. Some women talked about they don't have time to pay attention to their health for various reasons, but uh, Uh, but later on, hearing about the possibilities and the benefits of learning more led them further to state, yes, I will find time, but a lack of knowledge regarding cervical cancer, regarding screening per se, regarding pap smear, regarding general preventive gynecological testing, screening um, was a word discussed this. Of course, next issue discussed was what if the the screening shows poor results? What if I'm sick? So the discussion moved towards the need to have a follow-up. Next step involved interviews with close to 30 women all across the country in some settlements, small villages. We conducted these interviews to understand the behavior. Here we focused on the behavior of women, and the main topic
So what we have established is that many of these women are indeed overburdened in their everyday life. You know that it often happens that parents travel abroad. It is grandparents taking care of the children, or other situations where the family has many children to take care of. A prevailing attitude, regrettably, is that as soon as you have given birth to your children, you shouldn't pay attention to your reproductive health anymore. Some women respond that this attitude is due to bad past experience or to the lack of knowledge. Speaking about the barriers, the challenges, indeed, women are faced with numerous challenges. Some of them have their historical reasons. In addition, the current context is yet another factor explaining this attitude, meaning the attitude towards the prevention of cervical cancer. These women were the intermediary link, so to say, towards the current stage. What we are doing right now is we are working with a specific group of women in order to develop the digital stories, in order to have positive messages that are based on these women's specific experience. I would say that this experience is brand new for many of these women. They don't have any previous experience with being members of such groups, in particular, women living in remote areas, women from the Roma community. We didn't know what we could expect from these women, whether they would get involved. Speaking about the women who had already been our respondents. For the time being, we are particularly inspired by the outcomes. The women from these groups already are aware of the fact that they are our partners, that they act as a kind of experts, that we're all equal. They know that what we're doing is helping them to generate their story and their message. We provide the technical support. It is the women themselves that have to take the specific steps in order to create their digital story. 11 women are involved in this group, 11 of the women with whom we had worked, as well as 3 researchers from our centers. We hold regular meetings. We have a group in the social media. It is a kind of a chat box to share experiences, to raise issues. We started by presenting the technology itself for developing, for generating a digital story, gave examples to the women. The next step was the women sharing with us their ideas, their initial idea about the story. Then we started working on the script. The next step, the storyboards, and at present, adding music to the stories, including their voice. So we explain to them that they should themselves tell the story so that their voice be heard. Another aspect, a well-targeted message. The idea behind these digital stories is for them to reach out to the relevant communities. You can see a couple of examples of the storyboards. The first step, writing the script, then splitting it into parts. This is so that photos, the videos can be attached to each and every part of the story before producing the whole video. This is the stage that we have reached, is the stage of the storyboard. The women have been very active so far. They were more than willing to write the script for their story. So all the women who were initially involved continued working on their stories. Their stories are very emotional. All of them tell a story about something particularly relevant to them, be it experience or some concerns, fears, as well as the positive, the encouraging message. We have had a very active exchange of information and experiences within the group. For the time being, we are happy with what we have developed so far. Hopefully, we're going to have 7 or 8 such videos at the end of the process. I've already pointed out that by using these digital stories, we pursue using personal experience and reaching out to the community on the one hand, on the other hand, overcoming barriers, challenges that women are confronted with, namely having prophylaxis, taking care of their health, creating a kind of a fundamental within the community, or ensuring the prerequisites within the community in order to have screening programs in reality. We do not have a screening program in Bulgaria. Some of the communities have their individual initiatives organized by means of mobile groups. What is needed, however, is awareness raising, using the so-called health mediators, supported by local doctors. But these are individual initiatives and individual attempts. Based on the stories told so far by these women, what comes out is how relevant personal responsibility is. Namely, each and every woman should be personally responsible with respect to her health, with respect to her children and the family as a whole. So ensuring proper care for the whole family is also a very important topic. Some of these women have experience with living abroad, and they know what prophylaxis prevention is like abroad, and they can make the comparison with Bulgaria. They are aware of prevention measures, be it HPV vaccine or screening for different oncological diseases. Another very important aspect, the importance of dialogue and communication within the community, namely sharing your knowledge, your information with the others in the community. Information about the disease, about prevention, as well as facilities where you can have a medical examination. That was by and large my presentation about our projects, about the models that we use. gathering information, processing this information, and conveying the message to the communities concerned. Thank you for your attention. Thank you to everybody with whom we have been working, women, medical professionals, as well as our big international team. The international team that has been providing us with very useful information, and we have had excellent cooperation with them. Thank you.